about the peripheral nerve block for the lower limb. All right. So these are the anterior facial compartment of the thigh, the inguinal ligament, ASIS, pubic tubercle. These are the muscle of the interior thigh, iliacus, psoas major, rectus femoris, vastus, the cords, all the four cords, quadriceps femoris, that is rectus femoris, vastus lateralis, and vastus medialis. These muscles are these muscles. These are here. These are of muscles of the medial side. So we're talking about the muscles of the interior thigh. So these are the muscles of the interior thigh, including this one. And our neurovascular bundle, the favorite neurovascular bundle, the femoral nerve, the femoral artery and vein lies over here on the bellies of the iliacus muscle and psoas major muscle. Now the nerve supply of the interior, the whole lower limb of the interior side, the most part of the interior side is supplied by the lumbar plexus, femoral nerve coming from here, and the posterior side is supplied by the sacral plexus, the main nerve is the sciatic nerve. This is more elaborative diagram. You can take a screenshot. This is my favorite slide. Now the interior compartment belongs to the extensors of the knee, and femoral nerve is the main supply. The posterior compartment is the flexors of the knee, and it is main nerves is the sciatic nerve. The medial compartment is of adductors, and the main nerve is obturator nerve. Now I will be telling you about the femoral nerve. Femoral nerve, it is the largest branch of the lumbar plexus, and root value, as you can see, the root value L2, 3, and 4. Femoral nerve enters the thigh under the inguinal ligament between the psoas major muscle and iliacus muscle, and it is a nerve of the interior compartment. Relation with the muscles and vessels. Now let's have a look on that. Now again, this is anterior superior iliac spine. Over here lies the pubic tubercle. This is famous inguinal ligament. Our target nerve, the femoral nerve, it lies behind that. It enters the thigh just behind the inguinal ligament. As you can see, a very self-explanatory picture. And that is a cross section. You can say the transsectional area. Now over here, when you insert your needle, it pierces the fascia lata, first pop, then it enters the second one, that is, this is fascia iliaca, and femoral nerve lies under the fascia iliaca. So first there will be fascia lata, then it will pierce, your needle will pierce fascia iliaca, second pop, and just after careful aspiration, inject your drug. Okay. Now, the supply area of the femoral nerve. So this is very clear, self-explanatory picture. Cutaneous supply, as you can see, the anterior part and some of the medial part of the lower leg, in the thigh, the anterior compartment, but not the lateral side and not the medial side. So the myotomes, you can say the motor supply, only the muscles of the anterior compartment, about the bones, some part of the hip joint, the anterior part, not the posterior. Okay, as you can see, it is paired. The interior side of the shaft, not the posterior, and some part of the knee joint, but not the posterior part. So keep this supply, the area supplied by the nerve, and that will make it easier for you to think about the indications of the nerve block. So if you know the supply area of any nerve, you can supply area of the nerve, so that will make it easier for you to understand the indications of that nerve block. Now let me show you some of the indications. Outpatient knee orthoscopy, knee orthoplasty, total knee replacement. These are for the analgesia, not for anesthesia, okay? So total knee replacement, it can be used for analgesia. Anterior cruciate ligament reconstruction, analgesia in emergency department for femoral fractures, major knee surgery, leg amputation for analgesia, patellar realignment surgery. Now, femoral nerve block, how you do it. Yeah, first of all, important considerations. Motor blockade. This block causes significant motor weakness of the quads muscles, leading to an inability to extend the knee. Patient may require assistance with ambulation after the nerve block. Complications, potential complications are almost similar to any other block. There may be vascular injury, vascular puncture, nerve injury directly related with the needle injury, and the last that is a local anesthetic systemic toxicity. And there may be incomplete blockade of the knee. Now, how to locate it? First of all, you need to locate the anterior spheric iliac supine over here, the first arrow, blue arrow. Then the second one, you have to locate the pubic tubercle. Between these two lie the inguinal ligament. This over here, inguinal ligament. Now, just below the inguinal ligament lies the femoral artery. Palpate the artery, and 1 centimeter lateral or 1.5 centimeter lateral to the artery is the femoral nerve. You can go directly at 90 degrees angle to the skin, and when you feel the first pop and second pop, aspirate and give your drug. This is further elaboration. Some people, yes, I want to tell you one thing that is important. Some of you might know, but let me explain it for the beginners or the new people. Some people think the inguinal crease is inguinal ligament. No, let me tell you, this is inguinal crease. Inguinal ligament lies here between anterior spheric iliac spine and pubic tubercle. So this is inguinal ligament. This is inguinal crease. Don't mix inguinal crease with inguinal ligament, okay? So I have put this picture because of this reason, to just tell you the difference of the inguinal crease and the inguinal ligament. I know most of you people might be knowing that. So what happens? Position supine, no need to do abduction of the leg. That sometimes it does not, you do not require this. Now, blunted needle, insert it perpendicularly. First resistant, fascia lata, bounce, first pop. Second resistance mean you will feel a bounce, that is fascia iliaca. Second pop, and aspirate, confirm, and there's no blood and there's no pain, and then inject. 90 degrees angle to the skin. Now, this is a video I have recorded from the internet. That's not my video. Now, can you see? First bounce, first pop. With experience, you can feel the pop. Second bounce, second pop. With experience, you can feel the pop. And here you go. After careful aspiration, just give the drug. Let me show it again. First pop. Second bounce. Bounce means you are on the fascia iliaca. You have pierced it. Second pop is felt, and give the drug. Contraindications: needle phobia or otherwise uncooperative patient, excessive sedation. If patient is excessively sedated or have a low GCS, that is a relative contraindication, because you will not be able to assess the effect of your block, and secondly, it will be difficult to identify the last toxicity, the local anesthesia toxicity. So it is a relative contraindication. If there is local infection, it's a contraindication. Anticoagulation, again, it's a relative contraindication. And if there is a pre-existing nerve injury, try not to give the block over there. So thank you so much. Oh, my last slide. Because we have participants from all over, like from so many countries here. So thank you so much.